So I'm a postdoc working with Jihong Lit. I'm going to talk about some of our ongoing work on the effects of interventions on COVID-19 transmission in the US. So the COVID-19 epidemic in the US has been very severe and persistent, with the US now accounting for about a quarter of all confirmed cases worldwide. Excuse me, new policies have been introduced at all levels of government to help contain the spread of the virus. We're referring to these new policies, including things like stay-home orders, mask mandates, contact tracing, various closures as non-pharmaceutical interventions, or NPIs. In the US, most of these interventions were first implemented in March, and many were then relaxed in late May and early June, only to be reinstated again after widespread resurgences in the summer, particularly in the South and West. So in this project, what we wanted to do is characterize differences in COVID-19 transmission rates and preventive behavior associated with interventions. And here, preventive behavior refers to things like wearing a mask and staying at home. So ultimately, we want to gain insight into ways to better limit the spread of COVID-19. So this talk has three parts. First, I'll talk about differences in preventive behavior associated with interventions. Next, I'll talk about explicitly linking interventions to differences in transmission rates. And finally, I'll talk about how efficacy, timing, and duration of NPIs affect epidemic curves and risk of resurgence. And as a starting point, I wanted to make a note that the effect of an intervention on transmission rates depends on multiple factors. And here we're kind of decomposing it into two parts. The first half is the effect that an intervention has on actual behavior, for example, the tendency to wear a mask. And the second is the effect of the prescribed behavior on transmission. As an example, I'm showing three scenarios involving mask mandates. On the first row A, people wear masks without an intervention, but few people wear masks without an intervention, but most people do if required by law. So here, the intervention has a large effect. In the second example, adherence is low, and so the intervention effect is small. And in the final scenario, most people wear a mask regardless of policy, and so again, the intervention effect will be less pronounced. So when we look at the effect of interventions on transmission, we have to bear in mind that these aspects have been kind of woven together. So I'll move on to the first section about differences in preventive behavior associated with interventions. So this tells us about adherence to interventions, as well as how behavior has changed in places without intervention, both of which are important when we look at trends in transmission rates. So first, we look at differences in mask usage associated with mask mandates across the US. And to do that, we aggregated data from 4 sources. To assess mask usage, we used publicly available survey data gathered between July 2nd and 14th by the New York Times and by NIDA. To identify counties with mask mandates, we used data compiled by the COVID-19 state policy database. We also used daily reported cases from USA Facts and county-level demographic data compiled by Professor Ben Yu's group at UC Berkeley. So our data here is cross-sectional, and we analyze mask usage using a linear model with random terms to account for geographic correlation. We want to estimate the difference in mask usage associated with mask mandates, accounting for demographic factors and geographic differences in outbreak severity. The proxy for outbreak severity, we're using the log cumulative case rate, which is the number of cases per 100,000 residents per county, calculated up to the start date of the survey data collection period in July. And what we found is that mask mandates were associated with about a 10% difference in mask usage, accounting for demographic and other covariates. From the first figure on the left, we can also see that mask usage tends to be higher in counties with higher reported cumulative case rates, both in regions with and without a mask mandate in place. So this suggests that mask mandates have a substantial effect on mask usage, although we also see that adherence isn't 100%, and we see considerable mask usage, even in places where masks aren't required. In addition to mask usage, we also looked at movement trends and social distancing behaviors in relation to interventions. And for this analysis, the data sources are largely the same. In addition of the SafeGraph COVID-19 data consortium. So SafeGraph provides social distancing metrics derived from cellular data. And unlike the previous analysis, this is a longitudinal data set with one observation per day per county. The SafeGraph provides a number of different metrics, and we primarily focused on the estimated fraction of residents that left home each day. So this is longitudinal data, and so we need a model that accounts for correlations between measurements across time. But to do that, we used a generalized estimating equation with an AR1 correlation structure. And like in the previous analysis, we're also adjusting for demographic covariates, and we also include cubic B-splines with 8 knots to capture other time trends. And we estimate those separately for each U.S. Census division. We included 3 categories of intervention, which were stay-home orders, mask mandates, and a combined category that comprises business closures, including restaurants, bars, and other non-essential businesses, as well as social gathering restrictions. Those are all aimed at limiting situations where many people come together in the same place. What we see is that each of those interventions, actually including mask mandates, are associated with a higher fraction of residents staying at home, adjusting for time trends and baseline covariates. These effects aren't shown. Like the previous analysis, we also see that a higher fraction of residents stay home in counties with higher cumulative case rates based on reported cases. But so the rows here, counties are stratified by cumulative case rate within each month. So again, this suggests that preventive behaviors are more prevalent in places where the outbreak has been more severe. So in this next section, I'll talk about interventions and differences in transmission rates. For this analysis, the data sources are the same as in the previous section, but the model's different. Here, our response variable is the number of newly reported cases on a given day in a given county. And like in standard epidemic models, here's an expected number of new cases is RT times lambda t, where RT is the effective reproductive number, and lambda t is the so-called infection potential, which should be roughly proportional to the number of currently infectious cases. And we're actually using just a simple frequentist approach. It's an over-dispersed Poisson GLM, again fit by generalized estimating equations, and we're explicitly estimating the effective reproductive number as a function of baseline and time varying covariates, and again using an AR1 structure to account for correlations across time. So we adjust for baseline covariates, demographic variables, as well as time trends using cubic B-splines, which are estimated separately again for each U.S. Census division, and we have an additional offset to account for potential herd immunity effects. So the covariates here of primary interest are time varying intervention covariates. So here, yeah, we did not explicitly account for under ascertainment, but the model should be robust provided that ascertainment rate is stable over time. So here we again focus on 3 intervention categories, which were stay-home orders, mask mandates, and a combined category including business closures and social gathering restrictions. And also, I should note that we only considered mandatory interventions here. So we excluded things like advisories and recommendations. The rationale being partly that the recommended practice this is to avoid spreading the virus are sort of ubiquitous. And so when we say intervention, it seems most appropriate to consider policies that actually require people to do something as opposed to advisories, which are optional. So based on our model, all three categories of interventions are associated with significantly lower RT after adjusting for region-specific time trends, demographic, and other covariates. On the left, I'm showing let's see, case rates per time. So this is daily cases, new cases per 100,000, taken as a 7-day average for the 20 states with the most severe outbreaks based on the maximum value of the case rate per 100,000. And then interventions are shown by colored bars at the bottom. So most states have kept closures or some form of restriction in place more or less continuously since mid-March, although there are exceptions such as Oklahoma, and there are other exceptions for states that have had less severe outbreaks. Louisiana is another example. Stay-home orders generally started in mid-March, lasted through May. Mask mandates, the earliest mask mandates came in from the Northeast primarily, so New York, New Jersey, and in many states, mask mandates only started later on in the summer. And lastly, I'll talk about the impact of intervention efficacy, timing, and duration on epidemic curves. So in the previous section, we were looking at differences in transmission rates associated with interventions. But we're ultimately interested in the actual epidemic curves and numbers of infections that occur over time. And the relationship between these parts is complex because a change in transmission rate on one day is going to affect the infection potential on later dates, which creates kind of a complex chain reaction. So to characterize these effects, we use simulations. And we just use a simple simulation model similar to a standard Skeeter model. Here the input parameters are population size, serial interval distribution, transmission rate trajectory, a baseline rate trajectory, and a number of initial cases. So we simulate the number of new cases on each day, given the current numbers of susceptible infectious and immune individuals. And we can also relate the expected numbers of new cases under our simulation model back to the model that we were estimating in the previous section. So we simulated under a variety of intervention scenarios, varying the effective intervention on transmission rate, which is indicated by colors, duration of intervention, which is indicated by columns, and the start of intervention, which is indicated by rows. One of the main takeaways here is that relatively small changes in transmission rates can have enormous effects on overall epidemic curves and cumulative numbers of infections. We also see that if an intervention starts later or has a weaker effect, then it will have to stay in place longer in order to contain the virus. And these are the same simulation results, just showing cumulative infections rather than smooth numbers of new infections. So in summary, we found that mask usage and social distancing is frequent, even in places where interventions are not in place. And those behaviors tend to increase with outbreak severity across counties. However, it seems that this voluntary preventive behavior seems to be sort of too little and too late to contain the spread. Indeed, we saw that those behaviors are highest in places that have already experienced severe outbreaks. Our analysis suggests that interventions, including mask mandates and stay-home orders, are associated with substantial increases in actual mask usage and staying at home as expected, and that those interventions are further associated with substantial reductions in transmission rates. And the simulation showed that relatively small and temporary changes in transmission rates give way to drastic changes in epidemic curves and cumulative numbers of infections. And so together, these suggest that sustained efforts will be needed to contain the virus, given our current situation in the US. This study had a number of limitations. One notable limitation is that many interventions, including categories such as contact tracing and interventions that were implemented locally rather than at the state level, weren't captured in our analysis. There's also issues of non-random assignments of interventions, which can obscure a causal interpretation of our estimates. We also expect there to be variability in intervention effects, and we're focusing primarily on averaged effects. And there are also time-varying differences in lag between infection and reporting. There's under-ascertainment, and we didn't explicitly account for those, although some simulations suggest that our modeling approach is robust under certain assumptions. I also wanted to make note of some related work by my lab mates who have all been tremendously helpful on this project. Wei Li and Hao Yu Zhang have also analyzed national intervention effects on transmission rates, which is kind of a second half of this work. There's also a great interactive website, primarily developed by NBC, for real-time visualization of local and international trends in RT, case rates, and other key metrics, and some very interesting work on COVID-19 health disparities, and Bayesian models accounting for time-varying ascertainment. And then lastly, I'd like to thank all of our collaborators and my advisor, Xihong Lin, as well as the organizers of the SBC 19 for all their work for organizing this conference and so forth. So, I guess I'm finishing a couple of minutes early, but thanks, and I will take any questions.
Hi, Corbin. Thank you so much. We have a few questions for you. One is, are there any is there a database of intervention types by date, location, or is it just by the country and city level?
There is a large number. There's actually there's a data repository by Oxford recently. I'd have to look up the link, but it's a database of databases on exactly this issue. There's a large number of databases that collect intervention start dates across different regions at various levels of granularity.
Fantastic. If you're able to find the link, that'd be amazing if you could put that on the chat. Another question is, how do you adjust for time effects? Could time confound the masking mandate effect here?
That's a great question. What we did here was we just we lagged the effect of interventions by 2 weeks, reasoning that should be close to the typical lag between infection and confirmation. That's the approach that we took. There is some potential for bias. We also explored an alternative reading approach that's been used, but we actually found that there's a weighting approach that's been used in some previous literature. It seems to exacerbate the bias. So we just did a simple lag.
Great. And the final question before time is up. How do you define the start date of an outbreak?
Here we defined that as 50 cumulative reported cases. We also did a sensitivity analysis varying that between 20 and I think 100, and the results were pretty robust.